Let's start today's lecture. Today I'm going to talk about sex-caused stroma tumor, steroid cell tumor, germ cell tumor. Basically, in the ovarian, we have sex-caused stroma cells. I'm going to talk about what are they, and also germ cell. In a normal status, there is no so-called steroid cell in the human being, but we do have this steroid cell tumor. So here's the figure to show us what is sex-caused stroma cell. So here's the normal structure of follicle in ovary. And this outside layer is thick cell, and the inner layer is granulosa cell. So both of these cells are the origin of the sex-caused stroma. Then try to make perfect sense for why in thecoma and granulosa cell tumor, why some kind of these stroma tumor, sex-caused stroma tumor is related to antigen-related manifestation, and then granulosa cell related to estrogen, estrogen manifestation. You need to understand what is the normal function of these two cell type. So first, thicker cell, they receive the signal from LH, and then cyclo-AMP, it can activate these desmolase, transfer cholesterol to antigen. Then antigen go to granulosa cell. Granulosa cell receive the signal of FSH, then activate aromatase, which can transfer antigen to estrogen. So in granulosa cell tumor, your symptom is related to excessive estrogen, but it's not related to any symptom related to estrogen because it makes sense. Granulosa cell cannot secrete antigen. However, when you see the thicker cell, if you have thecoma, desmolase can transfer cholesterol to antigen. That means the symptom is related to excessive antigen in thecoma. But you can also see this pathway if you have more antigen. More antigen can also go to this normal granulosa cell. And then more of this product, antigen, it can also transfer to estrogen. So thecoma, you may have high antigen symptom or more estrogen symptom. Then another sex-caused stroma tumor in the ovary, that is the Sertoli cell tumor and Leydig cell tumor. And basically, they are just counterparts of the thecoma cell and the granulosa cell. Sertoli cell, the counterpart is granulosa cell, so it can also receive the signal of FSH and then secretes estrogen. Then Leydig cell receives the signal, and their counterpart is thecoma cell, so it can receive the signal of LH and then secretes testosterone, also estrogen. And then the IHC to highlight this kind of tumor is also makes sense. Why Sertoli cell express IHC marker inhibit? Because it can secrete inhibit. That is a negative feedback to the pituitary to inhibit FSH. So their counterpart granulosa cell also secretes inhibit, negative feedback for FSH. So inhibit is a IHC marker for Sertoli cell and granulosa cell. And then normally in the ovary, you cannot find Sertoli cell or Leydig cell, but these two cells can become tumor. So let's start to talk about the first entity for today. That is the adult granulosa cell tumor. So from the terminology, just the proliferation of granulosa cell with variety of pattern. The clinical issue is mean age is 50 years old. So compare adult granulosa cell tumor to juvenile granulosa cell tumor. They have older age for this patient group. And as I mentioned before, normal granulosa cell can use aromatase transfer estrogen to androgen to estrogen. So the symptom is related to excessive estrogen. And because more estrogen, our endothelial cell can become malignancy. And the stage is most important prognostic factor for adult granulosa cell tumor. It could be really big, like the mean size is 12 centimeter and unilateral. The cutting surface is yellow to white cutting surface. Here's the gross picture of adult granulosa cell tumor. The cutting surface is like meat-like cutting surface, yellowish. And then with this cystic structure. And then they can also have this multifocal, hemorrhagic, and necrotic cutting surface. The microscopic feature, I think usually we depends on the structure, the pattern recognition, as our low power expression for different kind of diagnosis. But however, in sex stroma cell tumor in the ovary, it's really difficult because when you see this pattern, they can have different kind of pattern, including diffuse, insular, tuberculate, core, microfollicle, different kind of pattern. So you just could not depends on this pattern to help you the differential diagnosis, though it is still helpful in the low power. And then for the exam purpose, coaxial body is the characteristic feature of this kind of tumor. And you should also notice, especially in the differential diagnosis, in this adult granulosa cell tumor, they have hyperthecosis. That means they have some area just really mimic thecoma. And then they also have cellular fibroma-like stroma, which is a mimic of cellular fibroma. So when you see thecoma or even cellular fibroma, you also need to think about whether it is just a component from an adult granulosa cell tumor. And then this time, reticulin staining is really helpful. I can show you the picture to help you better understand what I mean. And then the cytology for this adult granulosa cell tumor is really important. You can see scan minimum eosinophilic cytoplasm. And then the nucleus is conspicuous nuclei. You could not find any prominent nucleoli. And the more important clue is that longitudinal groove. But in the ovary, you also need to pay attention because Brenner tumor also a common finding in ovary, and then the cells of Brenner tumor also had this groove. So this is a really nice axonal, coaxial body. So what does that mean? That is the granulosa cell just forming this rosette and then have some secretion in the lumen. So in terms of coaxial body, but you need to pay attention. Maybe in the examination, when you see coaxial body, you can choose adult granulosa cell tumor. But in the real practice, you need to pay attention the mimicker, including endometrioid carcinoma of the ovary, gonadоblastoma, sclerosing stromal tumor of the ovary. All of these three entities could have this structure. And as I mentioned, we can have different kind of groove pattern. This is a solid sheet. And then this high power picture also highlight this nuclear groove. really minimum cytoplasm, and then the cells look really monotonous. And then also forming this core and change growth pattern. And this growth pattern is really rare, but you may also see it. That is a pseudo-papillary. Pseudo-papillary, that means you can see this almost like papillary structure, but you could not find any fibrovascular core. For the ancillary text, including ISC, for this text called stroma cell tumor, you always can find these three marker positive: inhibin, keratin, SF1, and then characteristic for adult granulosa cell tumor is FOXL2. And then as a stroma tumor, the epithelial marker like EMA and CK7 should be negative. And with reticulin staining pattern, just like what we've seen in the hepatocellular carcinoma, the reticulin fiber surrounding group or next of cell. But if in the cellular fibroma or the thecoma, this reticulin staining is helpful because reticulin fiber just dissect into individual tumor cell, not grab this group or next of cell. And then, of course, for molecular, we can find this FOXL2 somatic mutation in 95% of the adult granulosa cell tumor. So the differential diagnosis, including the first one, is our endometrial adenocarcinoma. But in endometrial adenocarcinoma, you should find some squamous or mucinous differentiation, and also associated with endometriosis. Of course, our epithelial marker is useful, EMA and PEX-A, as a relatively organ-specific marker. And then, of course, this inhibin SF1 FOXL2 negative. And then because granulosa cell, adult granulosa cell tumor can form in core and chains and solid sheets pattern. So carcinoid tumor should be always in your differential. But I think salt and pepper, chromatin is really characteristic for this entity. Of course, we have really good neuroendocrine marker like chromogranin, synopophysin, positive in our carcinoid tumor, and this stroma marker are negative. So this is a mimicker. We can see this. Oh, you may see this is coaxial body. However, this is endometrial carcinoma of the ovary. Even more make you more confusing. Some of these cells make this nuclear groove. You may think about adult granulosa cell tumor, but actually this is endometrial adenocarcinoma of the ovary. Then another differential, as I mentioned, in the adult granulosa cell tumor in the stroma, you usually will find this cellular fibroma-like stroma. But this is a true cellular fibroma, deforming this storiform vesicular growth pattern and lack of negative pattern by reticulin staining. So this is the reticulin staining of the granulosa cell tumor. So you can see this reticulin fiber just wrap next and group of cell, not dissect into single individual cell. Another differential entity is about the stroma, that is the thecoma. You may see some local area like this kind of thecoma in granulosa cell tumor. And then the cytology feature is characteristic. They have pale, abundant, grayish cytoplasm. And then they're forming this syncytial appearance. What does that mean? That means you could not find where these cells' cytoplasm end. So between these two cells, you do not know which cytoplasm is belong to which cell. So that is the syncytial pattern, and also related to estrogen manifestation. As I mentioned, normal sickle cell can use cholesterol transfer to estrogen, and more estrogen going into the normal granulosa cell, they may also transfer to estrogen. So thecoma can have both of these two hormone symptoms. And then immunostaining is not really helpful other than reticulum staining because it can also express carotene, inhibin, WT1, SF1. More interestingly, they can also have FOXL2 positive immunostaining. But this reticulin just going into the dissect of individual cell as a contrast to our granulosa cell tumor. You see this picture again because I would like to show you, really want you to remember normal thicker cell estrogen. Normal granulosa cell secretes estrogen, but more estrogen can also transfer to more estrogen. Okay, before we talk about juvenile granulosa cell tumor, let me show you some virtual slide. Okay, this is adult granulosa cell tumor. You can see this hyperchromasia area are the tumor. Even low power, you know this tumor have different kind of growth pattern. I zoom in a little bit. We have this kind of tumor cell forming this core and chain. Then they have this, also have this kind of grayish stroma, highlight stroma, forming different kind of growth pattern. But more characteristic, you can see this microfollicular pattern. And then find our friend coaxial body, tons of this coaxial body. This virtual slide just have 20x power, do not have high power, so you could not find the nuclear groove. But you can see, even here, you can see the cytoplasm is really minimal, and then eosinophilic. Like this. Then another area, also, you didn't know what is this pattern. Maybe a little bit pseudo-vascular pattern here, or maybe the artifacts, I'm not sure. But here, you can see this mimicking kind of like coaxial body here. Not really perfect, not like the previous area. Okay. Another sample of adult granulosa cell tumor. Here, even with this power, you can see the tumor cells are really monotonous. And then they have this solid sheets of glow pattern. And higher power, you can find maybe this is coaxial body. And then see the nuclear structure. This one is good to show you this nuclear groove, really nice. So in granulosa cell tumor, you try to find this cytology feature. And then this slide also shows really classic minimum scant eosinophilic cytoplasm, really minimum. That means you only can see this nucleus, and then the cytoplasm is really minimum eosinophilic. Just remember this characteristic feature. More importantly, this slide also shows the same H&E slide and then do the reticulin staining, show you this characteristic pattern, wrapping groove and mass of tumor cell in the granulosa cell tumor, as contrast to our cellular fibroma and thecoma. Okay, let's continue. Our next entity is juvenile granulosa cell tumor. From the name juvenile, we already know the mean age should be much younger than the adult type. And there is a phenomenon called the isosexual pseudo precocity. What does that mean? Why we call it pseudo? So if not pseudo, that is the true precocity. That means our sex development, like our breast, penis and or other hair, we will get mature in the true precocity as well as our ovary and testicle. However, when in this tumor, the patient had this pseudo precocity. That means we have the outside manifestation like the breast, maybe the penis, and then some hair follicles, our hair, but in the testicle and the ovary still immature. Then the related symptom is about amenorrhea or menstrual irregularity. But the prognosis is really good, 5 years survival rate is more than 90%. It may be associated with Ollier disease or Maffucci syndrome. The gene related to Maffucci syndrome, that is the IDH gene, it also relates. In this syndrome, you may find anchordoma and some hemangioma, especially spindle cell hemangioma, because IDH1 or 2 mutation also the driver mutation in spindle cell hemangioma. So just bear in mind. This is the growth picture of juvenile adult granulosa cell tumor. You can see this yellow nodule is the tumor in the ovary. The microscopic feature also, the architecture is really similar to the adult type granulosa cell tumor. That means you could not find really distinct, definite diagnosis pattern. They can form solid and follicular and also multinodular growth. But their follicle just vary in size compared to uniform microfollicle in an adult type granulosa cell tumor. Then the cytoplasm is really characteristic. Eosinophilia is not that good, but you can see really characteristic clear bubbly cytoplasm in juvenile type granulosa cell tumor compared to just eosinophilia, no bubble, no clear cytoplasm in the adult type granulosa cell tumor. So this is the multinodular pattern of the juvenile granulosa cell tumor. Then this is the follicle growth pattern, but you can see this follicle has different shape, different size. So compared to the uniform size in adult type granulosa cell tumor. And then here show you really characteristic, a little bit nuclei you can see, but no nuclear groove. And then cytoplasm is really characteristic, this clearing and even bubbly cytoplasm. And then the cytoplasm is more abundant than the adult type granulosa cell tumor. So bubbly, clear cytoplasm, no nuclear groove. The tumor cell also can grow around this follicle cyst wall, and then more apoptotic bile in this juvenile type granulosa cell tumor. The differential diagnosis including small cell carcinoma, hypercalcemia type. I do not have a picture here, but you can read this entity after this lecture by yourself, or maybe later I can make a lecture for the small cell carcinoma, but not right now. You just need to remember SMARCA4 expression. Loss of SMARCA4 is the characteristic marker for this entity. Then adult granulosa cell tumor, already mentioned, the patient should be older, coax nerve body, and then the follicle is more uniform shape and size, but more regular in size and shape. But in the juvenile one, we have different shape and different size of follicle. And then nuclear groove is characteristic for adult type, and lack of apoptotic body, and FOXL2 mutation. Of course, thecoma always in our differential, but it has grayish abundant cytoplasm, syncytial growth of the cytoplasm, And this reticulin staining is really characteristic and no follicle structure. So let's go to see some virtual slide. This is the juvenile time granulosa cell tumor. Even in this low power, really catch your eyes is a different size of space. That is the follicular or cystic structure. You can see different size of shape, really different from the adult time granulosa cell tumor. And then we can zoom in, we could not see coaxial body, and then zoom more, you can see this clearing, bubbly cytoplasm and more abundant than the granulosa cell tumor. So this feature is characteristic. You can always bear in mind different shapes and size of the cystic or follicle structure, no axonal body, no nuclear groove, and this characteristic clear bubbly cytoplasm and more abundant cytoplasm. This is maybe a mitosis figure. You can see some dirty background. That is the apoptotic body. I don't want to find more apoptotic body for you, but just show you this clear cytoplasm, really characteristic. This is a multinodular growth pattern of juvenile granulosa cell tumor. Even in this really low power, you can see different types or shapes of follicle. So you know, this should not be classic pattern for the adult time granulosa cell tumor. Should be juvenile type. Then no coaxial body, and then really this empty space around the cell, clear cytoplasm, bubbly cytoplasm, no nuclear groove. That is the juvenile granulosa cell tumor. See, this is absolutely not coaxial body. This one also forming even like pseudo lipoblast looking cell. Different shapes and size of this follicle cystic structure. Here is cytoplasm, bubbly cytoplasm, not really uniform for the cell. I can just show you real quick for the adult type. You can see when you contrast these two, just the cytoplasm you won't forget. See this really minimum cytoplasm, eosinophilic, no this empty space, no this bubbly coaxial body. Okay, let's see our summaries table. So all of these three are our sex-stroma tumor, as it's the same entity. Coaxial body for the adult type, scant eosinophilic cytoplasm, nuclear groove, but the immunostaining are the same, just the reticulin staining, wrap of necks of cell and adult type granulosa cell tumor. In the thecoma, just surrounding individual cell. And thecoma, remember, pale grayish cytoplasm with visual appearance. Juvenile type, clear cytoplasm. Okay, let's move on. Okay, our next entity is Sertoli cell tumor. It is related to Peace-Jaeger syndrome, and the mutation for Peace-Jaeger syndrome is STK11. You need to remember it for the exam purpose. Sertoli cell tumor, as I mentioned, the counterpart of granulosa cell tumor. So receive the signal from FSH and secretes estrogen, and also secretes inhibin as a negative feedback. But the symptom here, I don't know why it's still related to some estrogen manifestation, not just estrogen. But I think it may make sense because in normal ovary, you could not find this Sertoli cell. So maybe they become tumor, they can have different kind of behavior. Then the growth picture also similar. Yellowish cutting surface, it also can become a big one. Mean average size is 8 centimeters. The microscopic feature, I think you just need to remember the tubular structure because this is very characteristic. And the cell is also kind of characteristic but not really distinct. You can see we kind of deeply eosinophilic cytoplasm with this columnar cell, but forming tubule, that is really characteristic. See, forming this compact tubule, and then the tumor cells forming this next structure separated by this fibrous septate. High power, you can see this cell is forming this tubule with this empty space as a cytoplasm. You can still see the tube lumen just squeezed by the tumor cell and then forming this tubule. You need to pay attention, they can also form this endometrioid gland, endometrioid carcinoma-like gland, but still this is still tubule. But the immunostaining can really help us. The immunostaining also express inhibin, SF1, carotene, WT1. It also related to DICER mutation. What is the function of DICER gene? This is a really important gene for the expression of microRNA, and microRNA is a really important regulator to suppress the gene expression. So you can imagine if you lose this microRNA regulation system in your body, and then tumor just lose control of some oncogene, and then it is really important gene. And also this STK11, aka LKB1 mutation in Petechia's syndrome. The differential diagnosis, always remember we have this mixed cell tumor, Sertoli cell and Leydig cell tumor. So if you find abundant Leydig cell component, you may really have suspicion it's not just Sertoli cell tumor. It should be a mixed Sertoli-Leydig cell tumor. I will talk about Leydig cell tumor more later. And then melanin is the specific marker for Leydig cell in this entity. And also endometrioid carcinoma. In this entity, we should find some intraluminal or intracytoplasmic mucin, and also squamous differentiation. EMA PAX-A, our epithelial marker, our organ-specific marker, relatively PAX-A, and this sex-caused tumor cell marker inhibin and SF1 negative. Steroid cell tumor could be in the differential. I will talk more about it later, but you just need to remember steroid cell tumor and Leydig cell tumor actually they are the same. But if you think this is a Leydig cell tumor, but you could not find Reiki crystal, you should diagnose it as steroid cell tumor, NOS. And also this germinoma, because when you remember this Sertoli cell tumor can forming nest, and then this tumor nest is surrounded by fibrotic septa. This is just a feature of this germinoma, aka their counterpart seminoma in the testicle. The only difference is that in this fibrous septa, you can find lymphocytes, and then the tumor nest, usually they do not form any tubule structure. And also immunostaining for germ cell marker is really characteristic. Okay, next entity, as I mentioned, that is the Leydig cell tumor. Leydig cell tumor is related to high testosterone. That is the androgen-related symptom. Because I think you still remember, Leydig cell is counterpart is thecal cell. Thecal cell can receive the signal of LH and secretes estrogen. Then Reiki crystal is characteristic. This is the growth picture. You can see normal ovarian cortex just squeezed by this tumor and then become really thin. This tumor is relatively small, 2.5 centimeter. That's the average. Microscopic feature, I think just three are really characteristic. I highlight here. The first one is fibrinoid degeneration of vessel wall. I can show you the picture. Another one is the cytology feature of central nucleus in the abundant cytoplasm, and then small nucleoli. So low power, you will see this is really pink tumor as the Leydig cell tumor. If that is really blue and forming tubule, that is the Sertoli cell tumor. Reiki crystal, also characteristic. And then this lipofuscin pigment, just like what we see in the prostate as seminal vesicle, lipofuscin pigmentation. So this picture shows us really nice Reiki crystal. You need to find it to make the diagnosis of Leydig cell tumor. Then this central located nucleus and then punted nucleoli, eosinophilic, really eosinophilic pink color in the H&E staining. This shows this fibrinoid degeneration around this blood vessel, really characteristic. Also, always bear in mind there's a really pink tumor. The immunostaining, I just want to highlight melanate. Then steroid cell tumor, NOS. That is the tumor trying to mimic hormone-secreting cells of adrenal cortex. And then for the clinical manifestation is related to elevated serum testosterone, estrogen, and also the estrogen breakdown product in the urine, that's the 17-keto-steroid. 50% of the tumor related to high estrogen symptom, 10% related to estrogen. And then any of these features is related to poor prognostic. More than 7 centimeter, necrosis, hemorrhage, nuclear, atypia, more than 2 mitosis, 10 high power field. This is growth picture, just is yellowish cutting surface, kind of well demarcated. Microscopic feature is just identical to Leydig cell tumor without Reiki crystal. So this is also a really pink tumor, central located nucleus with punted, not really prominent, but you can see the nucleoli. You can see really pink color, and then central located nucleus with this nucleoli also in the center, recreated cytoplasm. They can, if I didn't tell you this is a steroid cell tumor, you may think maybe there's some artifact in adrenal cortex. But this is actually steroid cell tumor. With pink color, and then with this central located nucleus with a little punted nucleoli, no Reiki crystal. The immunostaining are the same with the Leydig cell tumor. And 2 immunostaining is helpful to differentiate some of these stroma cell tumor. WT1 positive in granulosa cell tumor, thecoma, Sertoli cell tumor. Then FOXL2 positive in granulosa cell tumor, mainly thecoma, and some Sertoli cell tumor. Both WT1 and FOXL2 are negative in steroid cell tumor. You need to bear in mind that it is impossible to differentiate if you want to tell whether it is metastatic adrenocortical carcinoma or this steroid cell tumor NOS under the microscope without any clinical history. Another entity is the Sertoli-leydig cell tumor. You just think just need to think this is a mix of these two entities I already talked about. Remember this dicer gene, then just skip this close picture. So just these two cell type, Sertoli cell, you can find tubule and really blue background of Sertoli cell tumor, Leydig cell tumor, really pink, rinky crystal, prominent, nucleoli, central nucleus, round, reticulated cytoplasm. You can see this light of bluish area that is a Sertoli cell component, and this eosinophilic pink area that is a sheet growth of Leydig cell. Abundance of Leydig cell. This bluish that is the Sertoli cell. Again, some blue area with this eosinophilic pink area. That is the tubule of our Sertoli cell. This is the solid sheet growth of our Leydig cell. Well-formed tubule, this sheet growth Leydig cell mixed together. This is the Sertoli-Leydig cell tumor. They can also form this anastomosing tubule lumen from the Sertoli cell, and then this eosinophilic stroma, ionizing stroma. Immunostaining are the same. These three markers again and again: inhibin, carotinin, SF1 positive in Sertoli and Leydig cell area, and then myelin A just positive in Leydig cell area. Okay, this is summarized table. So these two actually are the same, but steroid cell tumor just the same as Leydig cell tumor without the rinky crystal. And both of these two had myelin A positive. And Sertoli cell tumor forming tubule, not pink. This one is blue. This two is pink. Blue forming tubule. That's the characteristic. Okay, for the germ cell tumor, I just use this table because in the testicle we are familiar with this germ cells entity, but I still want to highlight some of the method how I remember and differentiate all of these entities. So first one is this germinoma in the ovary. The counterpart is seminoma in the testicle. They form a nest of tumor cells separated by fibrous septate. The fibrous septate usually you will find lymphocytes. And then Yolk tumor, they usually forming this reticular microcystic structure and cellular dual body. That is the characteristic for this entity. And then embryonal carcinoma, they can form in granular and papillary architecture, but this is not really important. More important is that you think really ugly tumor cell in testicle and ovary. You should bear in mind embryonal carcinoma and choroidal carcinoma. But in choroidal carcinoma, you usually find multinucleated syncytial trophoblast, which you could not find it in embryonal carcinoma. So you need to really look at it and find it to call. And then the last entity is spermatocytic tumor. And then in contrast to our seminoma, the population in the spermatocytic tumor is much older than our seminoma. Seminoma usually just younger patient. Spermatocytic, you may find 60 years old, 70 years old. It's really rare in an older gentleman to get seminoma. So you need to think about spermatocytic tumor. And then not found in the ovary. No spermatocytic tumor in the ovary, just in the testicle. Characteristic is 3 cell type: small lymphocytes, light cell, in the medial size cells, and then the giant bigger cell. And then you can see I list 8 immunostaining to differentiate all of these entities. How I remember this, I just divide into two categories. The first four is the germ cell marker. And then in seminoma, this germinoma as a really strict parent, they have all of these marker positive, germ cell marker, OPT4, cell4, CD1171, aka c-KIT, PLAB. PLAB is placenta-like alkaline phosphatase. So all of these four markers should be positive in this germinoma. And then cell4 and PLAP PLAB are the most sensitive marker. So you should estimate when you do these two marker, you may see your germ cell tumor should be positive. If you find cell4 positive but PLAB negative, highly suspicious of spermatocytic tumor. Those Yosek tumor you may find either positive or negative. But this is a method how to remember. PLAB negative spermatocytic tumor. Then you just, based on cell4 and PLAB immunostaining result, you don't really care about the OPT4 and CD1171 to make the diagnosis. Though you can still do all of these four marker, and then you find cell4 positive germ cell tumor, PLAB positive, you are really comfortable to call germ cell tumor. Then if you found AFP and glypican B, both positive, that is Yosek tumor. If you find germ cell marker plus CD30 positive, embryonal carcinoma. Germ cell marker plus HCG, choriocarcinoma. So that is how I remember this immunostaining. Do not really pay attention to OPT4 and CD117 because it's really confused. Okay, just show you some marker. I can give you like 5 seconds to think about it and then I'll tell you the answer. So solid sheet, but even in this power you can see, oh, some cell is big, some cell is medium, some cell is really dark like lymphocytes. So this bleach cell type is characteristic for spermatocytic tumor. And then if you are thinking about seminoma, but you do not see any fibroseptate with lymphocytes, so even in low power, you do not think about seminoma. But you can bear in mind, put it in your differential before you have these high power characteristic cells. The next one. Okay, this is seminoma because we can see necks of cells separated by this fibrous septate, lymphocyte in the fibrous septate. You really do not tell, oh, maybe this is a bigger cell, small one, medium one. No, they look the same, really the same most of the time. This is seminoma or this germinoma. Remember the immunostain marker, all 4 germ cell markers should be positive. Classic one. I will highlight some cell here. Okay. If I don't highlight it, the first impression is that, oh, really nasty, ugly cells, really hemorrhagic. Then your major differential is embryonal carcinoma or choriocarcinoma. But when I highlight this multinuclear syncytial trophoblast, this is choriocarcinoma. And then our marker is HCG. The next one. Okay, papillary structure, really nasty atypical mitosis, cystic or microcystic structure, nasty cell, but no multinucleus syncytial trophoblast. So this is embryonal carcinoma, CD30 positive. And the last one. What's this? Sure, your body. What is your body? That is where we see this vascular lumen surrounding rosette by this tumor cell. This is the follicular reticular cystic structure characteristic for rosette tumor. AFP, glypican 3, characteristic marker. Thank you so much.